Good morning, everyone. It's a pleasure to be here today with you. I want to first give my thanks to Professor Shudong Lee and all the members of the organizing committee and the host, the World Taiji Science Federation, for the invitation to speak today. So it's a pleasure to be able to share with you some Taiji research in patients with chronic lung disease, and in particular, a study that we conducted in Boston called the LEAP study, Long-Term Exercise After Pulmonary Rehabilitation in Patients with COPD. So let me start by providing some basic information on COPD, or chronic obstructive pulmonary disease. So COPD is a syndrome of chronic progressive airflow limitation. It's caused by toxic environmental exposures, most commonly smoking. And these patients suffer with dyspnea, or shortness of breath. They suffer from exercise intolerance, and they suffer with deconditioning. And importantly, these patients have a very high risk of sedentary behavior or physical inactivity. So those with COPD are more sedentary when compared with control patients of the same age. And this decreased physical activity occurs in all stages of severity of COPD, even very early on with mild disease, and it only worsens as the disease becomes more severe. There's also a high prevalence of comorbidities such as anxiety and depression and musculoskeletal issues in this population, which further affect the ability for patients with COPD to perform physical activity. So we know that increasing physical activity is greatly beneficial in COPD. So increased activity is associated with better prognosis. Patients do better over time. It's associated with better physical and cognitive function. And it's associated with reduced risk of hospital admission. And in fact, decreased physical activity is the strongest predictor of mortality from all causes, so all-cause death in patients with COPD. And you can see that on this survival curve here. You might be familiar with the Global Initiative for COPD, the GOLD Committee. This is a collaboration between the National Institutes of Health in the United States and the WHO, the World Health Organization. And the GOLD Committee recommends increased physical activity for all patients with COPD. But beyond the broad recommendation, how exactly to achieve that is still left unresolved. So the 2020 guidelines say all patients with COPD should be encouraged to increase level of physical activity, although we still don't know how to best ensure the likelihood of that success. What has been studied quite a bit is pulmonary rehabilitation. So these are typically programs in hospital settings of 8 to 12 weeks in duration. They usually include exercise training, for example, a treadmill or a stationary bicycle or arm ergometer. They usually include strength training and some sort of education, such as education regarding medications or nutrition or disease management or smoking cessation. Some programs might include stress management counseling, and some might include breathing retraining techniques. And the good news is that for those that do pulmonary rehabilitation, these programs clearly improve exercise capacity, decrease breathlessness or shortness of breath, and improve health-related quality of life. The problem, however, is that these benefits are only helpful in the short term. So typically, within 6 months of doing pulmonary rehabilitation, the benefits are no longer present if the patients do not continue exercising. Thus, a lot of interest recently has been around maintenance strategies. So how can we get patients to continue exercising after pulmonary rehabilitation completion? So studies have shown that successful maintenance of physical activity after pulmonary rehabilitation can decrease risk for acute exacerbations and hospitalizations. And many strategies have been studied, including combinations of exercise classes in hospital settings, home-based exercise programs, support groups, or even telephone interventions. But these have all yielded mixed results, so some positive and some negative. And there's currently no commonly accepted strategy. Unfortunately, instead, what we often see is this spiral of disability in COPD. So this figure just illustrates how progressive dyspnea or shortness of breath and the patient's deconditioning and their inactivity, how this gets worse over time until eventually the individual has significant shortness of breath with very simple activities of daily living, or even shortness of breath at rest. So we are interested in how Tai Chi might help this. So I know I don't have to define Tai Chi to this audience, but I will just say that, in the West, Tai Chi is often described as a type of mind-body exercise. And that includes an exercise with a focus on mindfulness and self-awareness and body and breath awareness. For many medical patients, it can actually be a gentler type of exercise for those that are more deconditioned or those unable to do other types of exercises, such as patients often with COPD. There is a growing scientific literature examining Tai Chi as a therapy or rehabilitation in various populations. So for example, with some scientific evidence supporting Tai Chi for prevention of falls, improving cardiovascular disease risk, improving pain conditions, osteoarthritis, rheumatoid arthritis, improvement of cognition, neurological and movement disorders, as well as healthy aging. So this figure shows significant growth in the Tai Chi peer-reviewed studies indexed in PubMed over the past 40 years, and particularly illustrates the increase in the number of randomized controlled trials, or RCTs, as you see here in the red. So what are the advantages of Tai Chi for COPD patients? So Tai Chi is a multimodal exercise. So multimodal meaning there are multiple components there. So it integrates both mind-body meditative elements and mindfulness together with physical exercise. And that physical exercise can include low to moderate intensity aerobic exercise. It can include core strengthening and upper and lower body strengthening. It can include stretching, as well as neuromotor or agility training. And again, particularly for older deconditioned individuals, such as those with COPD often, it may be a more accessible or less threatening type of exercise that can help patients increase their self-efficacy or their confidence to exercise. So why Tai Chi for COPD? So this is a very simplified model that again just illustrates that it integrates three important components in COPD management. So as this multimodal exercise, Tai Chi has the movement and the physical exercise component. There's the breath awareness and the management of dyspnea or shortness of breath, as well as the stress and anxiety management. And each of these components can actually impact cardiorespiratory conditioning, as well as cognitive and emotional processes that are important that might help with COPD disease management. So this is a study that looked at mind-body exercise for COPD. And this was a systematic review and a meta-analysis where they put together the data from 16 studies, including 1,176 patients with COPD. And the studies were of mind-body exercises, including Tai Chi, yoga, and Qigong, which are all types of mind-body exercise. And the study reported evidence for benefit in the 6-minute walk distance, which is a measure of exercise capacity, in quality of life, particularly helping dyspnea, shortness of breath, as well as fatigue, and even reported some benefit in FEV1, which is that measure of airflow obstruction in pulmonary function tests. Another study, this is one fairly recent that was published in the journal Chest, And you might be familiar with it. It was actually conducted in China at the Xinning People's Hospital in Guangzhou by Professor Luo, together with Professor Polke from the Imperial College of London. This is actually one of the larger studies available in COPD, and it examined Tai Chi versus pulmonary rehabilitation in 120 patients with COPD. It was actually an equivalence study, which was designed to see if Tai Chi was just as good as pulmonary rehabilitation. And the investigators found that the two groups were actually very similar with respect to improving quality of life, improving dyspnea, improving quad strength, so lower extremity large muscle strength, as well as improving 6-minute walk, that measure of exercise capacity. So given that background, we developed the LEAP study to investigate Tai Chi to support exercise maintenance after patients completed pulmonary rehabilitation. So LEAP stands for, again, long-term exercise after pulmonary rehabilitation. And these were our objectives. First was to assess feasibility of a study examining Tai Chi as an exercise maintenance strategy after pulmonary rehabilitation in patients with COPD. To examine the role of Tai Chi compared to usual care to maintain the benefits gained in exercise capacity, in symptoms, and health-related quality of life after completion of pulmonary rehabilitation. And then to further explore and describe these changes with Tai Chi compared to group walking. We recruited eligible subjects from pulmonary rehabilitation programs across multiple Boston area hospitals. We had 91 patients randomized in a 2:2:1 ratio to Tai Chi, usual care, or group walking. And the intervention was 6 months long, and I'll describe the groups in more detail in later slides. There was a 6-month testing visit, including a post-intervention qualitative exit interview and 12-month follow-up phone call. And the main comparison was Tai Chi versus usual care again, but we also had that smaller comparison group of group walking to really explore an active control group. Here are the inclusion and exclusion criteria. So we defined patients with COPD through pulmonary function tests or chest CT imaging. We included patients of any severity of disease, so GOLD stages 1 to 4, and those that completed standard pulmonary rehabilitation in the prior 24 weeks. And our exclusion criteria on the right really ensured that we had a relatively stable chronic disease population, so not acutely ill patients, and the criteria really considered cardiopulmonary safety. Here's a list of our outcome measures. So in addition to measures of study feasibility, our main outcome was exercise capacity as measured by the 6-minute walk test. We were also very interested in physical activity and exercise engagement. And also multiple secondary outcomes included quality of life, dyspnea, mood, stress, social support, and self-efficacy. Again, that confidence to manage COPD, the disease, as well as confidence to exercise. We also tracked safety and acute COPD exacerbations. So we used a few different approaches in our statistical analysis. Given the pilot nature of our study, we focused on effect size estimates. In addition, we also conducted models to look at estimates of the difference in mean changes in outcomes between groups. And in exploratory analyses, we also compared those who had improvement in certain outcomes versus those with no change or worsening. And we also looked at within group changes. Our study also included qualitative analyses of of interview data gathered at 6 months during an exit interview. So a little bit about the intervention groups. So the Tai Chi intervention included 36 one-hour classes twice per week for 12 weeks, then weekly for another 12 weeks. A guided audio CD as well as a DVD were given to patients to facilitate home practice. And we asked the patients to try to practice Tai Chi at home for 30 minutes, 3 times a week. The supervised group walking classes were identical to the Tai Chi in terms of class duration and number as well as frequency, as well as the type of physical activity was matched. That is, low to moderate intensity aerobic exercise together with gentle stretching. So the participants walked at their own pace around an indoor gym, targeting about 60% of their maximal heart rate and targeting an appropriate range on a scale of perceived exertion. And like Tai Chi, the participants were encouraged to walk and perform their stretches at home for 30 minutes, 3 times a week outside of the classes. Patients in the usual care group received standard instructions after pulmonary rehabilitation. So they got an unsupervised home exercise plan. Participants in all 3 of the groups received an educational booklet with standard instructions on exercising at home and instructions regarding disease self-management. So here are some of the baseline characteristics describing our sample by randomized group, with the yellow highlighting those characteristics that had some imbalance in the groups. So overall, the sample was about 69 years old. More than half were male. The mean FEV1 percent predicted was 48%, with more than half having higher disease severity with gold stage 3 to 4. Mean pack smoking years was about 50, and more than a third were on supplemental oxygen. In terms of self-reported comorbidities, 1/4 had cardiovascular disease, 1/3 had cancer, and more than 1/2 had chronic musculoskeletal issues or back pain. So overall, the study adherence was good, with about 93% completing testing at 1 year. Class attendance was better in Tai Chi versus group walking, so 81% versus 64%. And there was actually reasonable home practice in both the exercise groups. So they were encouraged to practice 3 times per week for 30 minutes each session. So that would have been about 90 minutes. And the data here show an average of 80 minutes in Tai Chi per week and 73 minutes per week in group walking. In terms of safety, we did not see many adverse events. And with regard to COPD acute exacerbations, during the 24-week intervention period, the percentage of subjects with at least 1 COPD exacerbation that required treatment with antibiotics or steroids was 9% in the Tai Chi group, 19% in group walking, and 20% in usual care. There were no significant statistical differences between these groups. So in terms of our clinical outcomes, results were somewhat mixed, with some outcomes suggesting promise and others without much change. Our primary outcome was the 6-minute walk test, which again is that measure of exercise capacity. And we saw small between group effect size in change in 6-minute walk distance, favoring an increase in Tai Chi compared to usual care at 24 weeks. There was also a significant greater percentage of participants in Tai Chi who improved their 6-minute walk test distance compared to usual care, so 64% versus 39%. And then we looked at the within group changes. So within the Tai Chi group, participants actually walked 43 meters more on their walk test at 12 weeks compared to baseline, and 22 meters more at 24 weeks compared to baseline. And in contrast, both the usual care and the group walking had non-significant decreases in their walk distances. We also collected weekly physical activity logs. So we asked about activities outside of class or outside of home practice. And we calculated the total minutes per week that the participants engaged in other types of activity. And again, the main comparison is Tai Chi versus usual care. Overall, we did not find significant differences between Tai Chi and usual care with respect to total self-reported minutes of physical activity. However, we saw some very interesting observations when we looked at the individual exercise categories. So we saw that the usual care group engaged in more walking, more strength training, and more cardiovascular type exercises, which really matched the types of exercises that the patients had learned in pulmonary rehabilitation. In contrast, the Tai Chi group performed more everyday activities. So things like housework and yard work and even some sports. Very interesting. We also looked at composite exercise engagement. So that included total minutes per week of class time and home practice time for Tai Chi and walking, plus the other physical activity on the exercise logs. And this composite time was actually higher in the first 12 weeks in Tai Chi, about 540 minutes versus about 400 minutes in both usual care and group walking. But in the follow-up periods, all groups had similar times. When we looked at other secondary psychosocial measures, we found small effect sizes favoring Tai Chi over usual care in health-related quality of life and fatigue, as well as mastery and COPD self-efficacy. And these are both measures of patients' confidence and sense of control over their disease. We also saw higher percentages of patients versus usual care who improved their fatigue scores, so 59% versus 31%, as well as mastery scores, 47% versus 20%. We also saw significantly higher percentages of participants in Tai Chi who reported improved social support, 62% versus 25% compared to group walking. When we looked at within group changes within the Tai Chi group at 24 weeks, there were also improvements in COPD self-efficacy, social support, and perceived stress. In usual care or walking, group walking, there were actually no significant changes in these secondary outcomes at any of the follow-up time points compared to baseline. So in much of our research, we have utilized mixed methods, so both quantitative and qualitative analyses. So qualitative research, is valuable to better capture the individual patient voices and the patient's experiences, and really help us better understand and further explain the quantitative data. So when we ask patients to tell us about their experience having COPD before the study, they reported themes of breathlessness, shortness of breath, and associated fear and embarrassment of being short of breath that limited their physical activity. And we saw this across all three of our groups. Here are some of the quotes that the patients gave us. So one patient said, "It's upsetting and embarrassing. When you're walking with friends, you're short of breath. I try to keep up, then I'd be gasping. I understand the people who just give up and stay home." Another person said, "The people I saw in the gym were so far advanced, I almost felt embarrassed going to the room with them." And then another said, "I'm afraid to do things that make me feel uncomfortable, like physical activity. If it's going to cause shortness of breath, I try not to do it." Then we asked the participants how the study interventions might have changed their experience. And in both the Tai Chi and the walking groups, participants reported improvements in energy and endurance. Then we saw themes that were unique only to the Tai Chi group. So these patients shared about body and breath awareness, emotional control, and regulation of their breathing. And they really described a different way to manage their shortness of breath, their breathlessness experience that really helped their ability to do daily activities. So for example, one patient said, I'm more aware of my body, just being in touch with how I feel physically, and that ties in with my psychological condition. Another said, I noticed I had held my breath when I should be breathing. I realize you can pay more attention to your body. Your body is something to take care of and pay attention to. Another said, if I get into a situation that's stressful, I can use some of my Tai Chi techniques to relax. It made it not as difficult to control. I have less stress around breathing and less fear. Another said, Tai Chi has given me another way, taking care of myself in a more responsible and safe manner. I'm not push, 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 and then gasping and in a panic mode. I'm not doing that panicky stuff. Tai Chi has changed that. So with this analysis, we developed a theoretical model that describes how a multimodal mind-body exercise like Tai Chi may help patients with COPD. So through cognitive and emotional processes, Tai Chi may decrease the fear and embarrassment associated with breathlessness. And together with the physical function improvements and the energy and the endurance improvements, this can help to facilitate physical activity and improve function and quality of life in patients with COPD. Some of the themes that came out in our qualitative analysis very nicely illustrate the anxiety breathlessness cycle that is very well known in COPD, and how we might consider patients using what's learned through Tai Chi and other mind-body exercises to possibly break the cycle. So just to illustrate, the cycle starts with shortness of breath while doing physical activity. And this in the patient will trigger an emotional response like anxiety. And that triggers a body response, such as a fast heart rate or fast and shallow breathing and tension in the body. And that triggers more anxiety, which then leads to the behavioral response of avoiding physical activity. And this, of course, then leads to further deconditioning of the patient, and the cycle continues, right? So Tai Chi can potentially promote emotion regulation, body awareness, and self-efficacy to potentially break this cycle. Okay, so to summarize the LEAP study, we found that studying Tai Chi in patients with COPD is feasible and safe. Adherence was good. Class attendance was better in Tai Chi than the other groups. And there may be a small, modest effect in change in exercise capacity with Tai Chi compared with usual care. Tai Chi may also be associated with improvements in quality of life domains, such as fatigue and mastery of their disease. And like previous studies, however, improvements at 24 weeks in exercise time may not be sustained at 1-year follow-up. And this really suggests that long-term sustained behavior change remains a challenge in COPD. We also learned that processes such as emotion regulation, body and breath awareness are all important to consider and further study. And Tai Chi may act on decreasing fear and embarrassment associated with breathlessness to facilitate that physical activity engagement. So our next steps for this research might include further studies with larger sample size that have full statistical power. We might think about optimizing the intervention and targeting certain populations. So I'm interested in gaining a better understanding of which of these chronic pulmonary patients will most benefit from a mind-body exercise option. and perhaps also applying it to other cardiopulmonary populations with exercise intolerance, like maybe long COVID. Right? And finally, what we learned from this work is that likely no one model of exercise maintenance is probably going to be ideal for all patients with COPD. So maybe a personalized maintenance exercise programs and multiple options post-rehabilitation might be needed to really optimize physical activity in this population. And Tai Chi may be one important contribution there. Acknowledge the many people that were involved in conducting this study, as well as the sponsor. And thank you very much for your attention.